Well, good morning, everyone. Today I will be debating that a ULD nivolumab should be the standard of care in the management of recurrent metastatic head neck cancer. I'm speaking for the motion. So these are my disclaimers. All the information is based on scientific data. I do not intend to pass any remarks on person, pharmaceutical company, or any political party. There is a component of exaggeration which is quite natural to make it more dramatic, and there is something called a debate bias being there with my argument. So, I would thank the organizers for this opportunity. And before we accept these terms of ultra low dose, we should be a little careful before we accept these terms because these can be misleading. And we politely disagree because we have our own ways of looking and we are entitled to have our own choices. So rather, I would reframe my debate topic as optimal dose immunotherapy, the untold story. And it looks deadly, dangerous because depriving a patient who is eligible for immunotherapy and not giving is equally harmful than doing harm to the patient. So only 3% of patients who are eligible for IO have access to IO. This is not fair. Therefore, I will say some untold story about an optimal dose of IO, which you've never heard. And this is probably how the story begins. So there is a guy by name Mullah Nasruddin who was traveling on his donkey in a desert, and he gets in touch and meets someone who sells water. And when he goes to buy water, he just wants a sip of water for his thirst, but the minimum available water is just 40 ml for which he has to pay 40 rupees. But the rule for trade here is you must buy 240 ml for quenching your thirst. And if you buy 100 ml, you'll get 140 ml free of cost. And the cost comes to just 100 rupees. So this is a sort of strategy they used. And there are a few more conditions for it. You must buy 240 ml every 2 hours, irrespective of whether you're thirsty or not. You must buy 240 ml, irrespective of whether you are tall, thin, short, obese, doesn't matter. Your dose is 240 ml. And if you deviate from this schedule, dose or the frequency, you will not be given assistance, or the free bottle will not be there. And there is some effort for an intentional shortage of 40 milligram vials or 40 ml vials, 40 ml bottles for that matter. So these are some conditions, and this is what we see in the real world scenario. I think probably you'll be able to translate this. So what's my job in this debate? First of all, I'm not here to debate. I'm not here to say ULD, the so-called ULD NEO equal standard dose NEO, but I'm here to say what should be the optimum dose of IO. In all debates, let truth be thy aim, not victory or an unjust interest. So, what is the clinical evidence of the ultra low dose NEVO? We have a randomized controlled trial from Tata Medical Center. Uh, so its TMC is both triple metronomic chemotherapy NEVO or Tata Memorial Center NEVO. So has shown overall survival benefit. This is one evidence, and we have some retrospective studies saying that low dose NEVO does work. And this is the proud representation from our Indian subcontinent in ASCO by Dr. Vijay. And this is how the trial design is. Excellent trial design, qualifying for metronomic therapy or immunotherapy. And the primary endpoint is overall survival. And this is the response rates, statistically significant response rates. And this is how the overall survival looks like. The hazard ratio is 0.5, which is impressive. And you can see the separation. It's phenomenal. So for the first time, for a long time after cetuximab, we did see an improvement in overall survival in this difficult subgroup population. Remember the hazard ratios. Remember the median OS is 10.1 months. So this is the conclusions from the author. Like, to our knowledge, is the first ever randomized trial to demonstrate overall survival with low dose NEVO with metronomic therapy. and is an alternative standard of care for those who cannot have access to full dose checkmate inhibitor. That's the conclusion they have. And well, this is a checkmate 141 design, and this is the randomization of Nivo versus chemo, and significant for overall survival, hazard ratio 0.68. And I know, we cannot compare our apples and oranges, Dr. Vamshi would say that, but the overall survival is 10.1 versus 7.7 months, and the hazard ratio for overall survival is better in the TMC Nivo study. So, well, do we have the final answer? Final answer will come only when you have a randomized controlled trial of ULD Nivo versus the so-called standard Nivo. Who will fund? And it will never happen. And this is some more evidences in non-small cell lung cancer where there has been a retrospective comparison of standard dose versus low dose Nivo, and here low dose Nivo does better than standard dose Nivo, or at least comparable. So this is the difference you have. And small countries also use low dose Nivo in 16, 17, and let's find the optimum dose of nivolumab right now. So this is how the dose response curve looks like. The more dose you give, the greater the benefit is. Larger the dose, better the benefit. But after a particular dose, the benefit plateaus. This is what is a dose response curve looks like. This maximum tolerable dose funda, it holds good only for chemotherapy. In chemo, what we do is in phase 1 trials, you give the highest dose, get the maximum benefit, and above which the patient cannot tolerate. This holds good only for a cytotoxic chemotherapy and not for targeted therapies. And this is how the design of a dose finding study for cytotoxic chemotherapy works like, and that's how you calculate the recommended phase 2 dose. And remember, there is a difference between a minimum effective dose and a maximum tolerable dose. And remember, this is how the therapeutic window is different for a chemotherapy versus a targeted therapy. A minimum effective dose versus maximum tolerable dose, there's a lot of gap. There's a lot of room for unnecessary increase in the dose, and that's the reason why you would see overdosing of majority of targeted drugs, including bevacizumab. And what is important is you need to find out not the MTD, but the biologically effective dose. And what are the basic facts about IO dosing? They may not benefit from more is better approach. Determine dose based on efficacy and not on tolerance. And there are some bodies that say that approach what is known as the Project Optimus campaign. Means give approval only for optimal dose and not for overdosing. And we must switch from the endpoint of maximum tolerable dose to biologically effective dose for IO. So eat how much, eat sufficient enough to manage yourself and don't overeat to fill your esophagus. And these are some initiatives taken to optimize the dose of IOs. And along with that, we need to redefine the efficacy endpoints for biologically effective dose. For chemotherapy, you have to assess for assessing the response rate, to assess for tumor size shrinkage. To assess these responses, you need a lot of resources. You would need a large trial, which needs nearly a randomized trial would need 600 vials of nivolumab. That's upon to 6 crore rupees. And whereas if you can assess indirectly the target receptor occupation by simple flow cytometry, which does not need so many vials, this is a better way of assessing the efficacy for the biologically effective dose rather than doing a randomized trial and showing and assessing the tumor size. So with this, we all must urge for dose revision, and you don't reduce the dose just because the side effect was high. For example, in regorafenib, we came down to the dose because of side effects. But we must also start revising the dose when we understand that lower doses are also effective. So what's the correct frequency of nivolumab or IOs? Or the 2 weekly, 3 weekly, 4 weekly, 6 weekly? Do we have evidence? Yes, we have reasonable good evidence. And this is based on the half-life. You can see the half-life is 25 days for Nivo and 23 days for Pembro. But still, Pembro is 3 weekly, Nivo is 2 weekly. There is no reason for Nivo to be given every 2 weekly when the half-life of Nivo is longer. Therefore, feel free to alter the frequency and be liberal to alter the dose and frequency. This is a trial where they have compared 240, 360, 480 Nivo, and they say when you give 2 weekly, 3 weekly, 4 weekly, does not matter. But remember, you cannot give a larger dose and make it act for a longer period of time because it doesn't work like that. The pharmacokinetics is it follows first order kinetics. Even if you give a higher dose, the half-life is going to be constant. Therefore, indirectly from these trials, we understand whether you give 240, 360, 420 doesn't matter. Doesn't matter. And whether you give it 2 weekly, 3 weekly, doesn't matter. Therefore, this is an indirect evidence where whether I give whatever dose frequency, it doesn't matter. This is another trial from melanoma where Nivo EP, Nivo 3 EP1 compared with Nivo 1 EP3, which is given 3 weekly, and it is similar. The efficacy is similar. Nivo 1 3 weekly is sufficient in the study. Look at the PFSOS, no difference. The curves are just lying on each other. But the conclusion is sort of, they say I cannot conclude on the efficacy part, but I can only say the side effect is better if I give less EP. So what is the rationale behind actual biological effective dose and frequency? So 90% of receptor occupancy happens at just 0.1 milligram per kg of nivolumab, and then it plateaus. Above that, doesn't matter. For a 60 kg individual, you give 6 milligram of nivolumab, that's sufficient for 90% of PD-1 receptor occupancy. After that, whatever dose you give, doesn't matter. The target occupancy persists for up to 3 months even after stopping the drug. The required concentration is 1 to 2 microgram per ml. Whereas what we are giving right now is 28 times more dose than what is required. And whether you give it 0.1, 0.3, 1, 3, 10 per kg of nivolumab, doesn't matter. The responses do not change. So we also have good evidence that the tumor shrinkage does not improve with increased dosing. These are some pictorial representations of how low-dose immunotherapy causes excellent regression and healing of head and neck cancer. So what should be the optimum dose and frequency for a 60 kg individual? 10 milligram every 3 monthly. And the cost is 3,000 per month, just like palbociclib. What are the bitter facts to introspect? No biomarker. Give everyone only 3 out of 10 benefit. At least 4 doses must be given to understand the benefit. 4 dose everyone irrespective of weight. Keep giving endlessly even after progression, and perhaps stressing on 2 or 3 weekly cycles. And are all this coincidental or all this with a pre-intended purpose? So stupid is knowing the truth, seeing the truth, but still believing in lies. So my conclusions are the terms ultra low dose and standard dose should be revised to optimal dose immunotherapy. Optimal dose Nivo, if you can give, which was given in a triple metronomic therapy randomized control trial, showed an improvement in overall survival. The hazard ratio is very impressive. What else you want? Just should not use the maximum tolerable dose as the endpoint, as the way of dosing for immunotherapy. You must use biologically effective dose. You must change efficacy endpoints from response rate to target receptor occupancy. There is sufficient evidence for optimum dose. You've got phase 1, 2, 3, 4 trials. Join hands for Project Optimus. Urge for dose revision. Optimal dose IO must be the standard of care on a Monday morning and improve access to all our patients. So this is the fact where less than 3% of Indian patients can access immunotherapy, but if you can take steps boldly and implement optimal dose immunotherapy, you can increase access to majority of patients. I thank all of you for your patient listening.